Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Oneet Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by ISAC, the International Academy on the Science and Impact of Cannabis. Visit their website at isac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Get ready for a painful conversation. I'm your host, Dr. Oneet Lev. We're going to talk about pain. Pain was declared the fifth vital sign after temperature, heart rate, blood pressure, and respirations in 1996 by the American Pain Society. I was a young doctor at the time, and the fact that pain took fifth place as a vital sign pissed me off. I wasn't upset because pain is subjective. Some of my patients had a pain scale of 2 in the midst of a major heart attack, and others had a pain scale of 20, off the charts from the 1 to 10 scale, while eating chips and texting on the phone. I also wasn't angry that the pain scale was the invention of the pain doctors, funded by Purdue Pharma to promote OxyContin. I had no idea that connection at the time. I was angry because pain took fifth place over oxygen. Around the same time, the oxygen saturation machine became readily available at hospitals. I thought oxygen or breathing should be the fifth vital sign, not pain. I wouldn't mind if pain was a sixth vital sign, but how did it cut in front of the line of oxygen? I became a quality reviewer for Medicare and noticed that physicians and hospitals were getting dinged for not addressing pain. A quality complaint from the government would state that a patient entered the hospital with a pain scale of 7 and discharged with a pain scale of 5. Why was more not done to treat the pain, doctor, hospital? I defended the doctors in these cases. If you want to guarantee a pain scale of 0, you need to be dead or on a ventilator. Don't worry, I didn't actually write such an official response, but I thought about it. In San Diego, I brought the community together to write safe prescribing guidelines for pain and a One San Diego plan to coordinate medical care regardless of the role in the healthcare family. Our San Diego guidelines were used 3 years before the CDC stepped in and published their gold standard guidelines. The pain scale is not completely dead. I still like asking heart attack patients if their pain scale improved after giving nitroglycerin. I like asking back pain patients if their pain scale changed after a trigger point injection. But the goal is not 0 pain. I don't want my patients dead or on a ventilator. And with that, let's hear our question of the day.
Hi, Dr. Lev. This is Justin. I'm an emergency medicine pharmacist. I've worked with you over the years, and I've really enjoyed working together with you. We've worked on projects, on initiatives, on research together, and just wanted to say that I'm really grateful for our professional relationship together. For those of you who don't know, we as emergency medicine pharmacists work closely alongside our physicians and our providers to assist with medication selection, medication decisions. We help determine what would be the most safe as well as effective for our many patients who walk through the doors of the emergency department. And so today I have a question for your High Truths podcast. I know recently the CDC released updated pain management guidelines. For us as providers and pharmacists in the emergency department, what do you think are the key things and the key takeaways that we need to know that would impact our patient care? Secondly, do you know if the CDC is going to regularly update these guidelines similar to other guidelines that they put out, such as the guidelines that they put out for sexually transmitted infections?
Thank you, Justin, for your question. Emergency department pharmacists are the guardian angels to doctors in the emergency department. You make the doctor smarter in deciding antibiotic choices, COVID treatment, reversing blood thinner medication reaction in people who are bleeding, real-time support during code blue cases, and so much more. Every busy emergency department should have highly trained emergency pharmacists, and I'm so thankful that you make our emergency department care so much better. To answer your question about CDC pain guidelines, I went straight to the source, the doctor who actually wrote the guidelines. And today I'm excited to talk to Dr. Roger Chou. Dr. Chou is professor of medicine and medical informatics and clinical epidemiology at Oregon Health and Sciences University. He's an international expert on opioids and pain. He works with the World Health Organization, the National Academy of Medicine, and the CDC. Dr. Chou is one of the main authors for the CDC Clinical Practice Guidelines for Prescribing Opioids for Pain, initially published in 2016 and again in 2022. To learn more about Dr. Roger Chou, please check out the High Truth show notes. Dr. Roger Chou, welcome to High Truths.
Thanks for having me.
I'm very excited to have you and talk about pain and the CDC guidelines. And your specialty is in pain, but you're trained in internal medicine because, I don't know, when I started, there was no such thing as a pain specialty. How did you come to that profession?
Yeah, so my clinical background is actually general internal medicine, and I've done primary care for 25 plus years. I started, I did a health services research fellowship at the VA, and I started doing systematic reviews, technical reviews for the Evidence-Based Practice Center, which was here at OHSU. And as part of that, I started working with the American Pain Society on their clinical guidelines program. And, this was way back in 2004 or 5, when we were just starting to realize there was an issue with opioids. And they wanted to do a guideline on opioids, and I was serving as, we had a contract with them for me to serve as the Director of Clinical Guidelines Development. And we actually did the first national guideline on opioids for chronic pain. That was in 2007. So, preceding the CDC guideline by 9 years or so.
Is that pain society? There were several pain societies. Some of them were funded by pharma and some weren't. I can't remember which is which. Which is the one that wrote the guidelines?
So the American Pain Society did receive pharma funding, but it wasn't part of the guideline process. There were some firewalls in place. The American Academy of Pain Medicine was actually also part of that guideline. And the American Pain Society shut down, so they're not in existence anymore. But at least my experience was, and the way it was set up was there was no, pharma had no involvement in the guidelines.
Are those the guidelines? And I can't remember that I reviewed at the time were like, if this person has in pain, then add some more, and then add some more, and add some more opiates.
No, I don't think so. I mean, these guidelines, I would say, are actually pretty similar to the 2016 CDC guideline. We were the first guideline to actually, the first national guideline at least, to say, wait a minute, maybe you shouldn't just keep titrating up. We at the time, we proposed a dose threshold of 200 milligram morphine equivalents. But before that, there was no dose threshold. If you remember those days when the idea was, you can just continue to increase the dose as long as you do it slowly, there's no problem. When we looked at the evidence at that time, we were, there was no studies supporting those practices, right? If you look at the randomized trials of opioids, they were all using doses, maybe up to 80 morphine equivalents at most, occasionally up to something like 100 or 120, morphine equivalents, but, never over 200. And it was really unclear, what the data were. And that was when we were starting to see a lot of overdose risk. We didn't have any of the studies yet about the association between dose and overdose, like the dose-dependent risk. And so it was difficult to make a recommendation, but we did. And the recommendation was, don't go over 200 milligrams except in, very limited circumstances. And there was a lot of anger at that time. I remember being at national meetings and people yelling at us and saying, why are you trying to restrict, the way we prescribe?
Oh, you were being yelled at for being too restrictive. That's in 2007 or 2016?
Yeah. Yeah, both. But this is 2000. This is actually 2009. I'm sorry, I had the date mixed up. This is 2009.
Yeah.
But yeah, there were people quite upset, and the other group that had done that or was doing that was Washington State. So Washington State,
Yep.
Around the same time that our guideline came out, the Washington State Agency Directors Group put out a dose threshold of 120 milligrams. That group is led by Gary Franklin. And they got a lot of flack for that as well. But again, they were seeing the same kinds of data, lots of overdoses, unclear, safety of using really high doses, and really not good evidence to support we just didn't have studies, showing what the benefits and harms were at very high doses. So, yeah, that was 2009. And again, I think that was kind of the long path to the 2016, CDC guideline is, the societies issued that. I think a lot of the principles in that, if you go back, I haven't read that guideline in a while, but if you go back and read it, I think a lot of the principles are still principles that we support now. And I'll just say that at the time, I was trained in the 1990s when opioid use was exploding, right? That's when we saw a fourfold increase in prescribing of opioids for chronic pain over about a 10-year period, 1990 to 2000. That's when OxyContin, became one of the most
shoved
prescribed
down
drugs.
our throats. It was like, you need to prescribe, right? You can't be.
Exactly. We were told that OxyContin. There was a confluence of factors that happened, right? So, there's a lot of people with chronic pain. There was a perception that we were withholding opioids, which were perceived as being very effective, because of safety concerns. And then there were a lot of ideas about, well, you can prescribe it safely in palliative care settings and cancer settings. Why can't we use it for people with chronic pain? Some case series, some opinion leaders, et cetera. And then at the same time, there were these, drugs that were these long-acting drugs that were being very aggressively marketed. And, so this all happened over a 10-year period where the prescribing practices in this country changed very dramatically. It was like a huge national experiment, and really based on, very little data.
Right. And it's amazing how national guidelines, since you're a guidelines expert, changed within those 10 years, right? The first guidelines were like, no one gets addicted if they have true pain. And then fast forward 10 years, which is a very short period of time, really, saying no, 100% of people get addicted if they continue with opioids.
Yeah, I wouldn't say 100% of people get addicted, but I think that the risks were not recognized, and there was a lot of overlap between industry and the people that were making the guidelines originally. Some of the folks had hopped from the federal government to private industry, and they were still prominent in the field. We didn't have the same kinds of a lot of the opinion leaders were, also people that were speakers for pharma. And we didn't have the same kinds of, safeguards that for conflicts of interest, I think that we have now. And, my opinion is that many of these people did think they were helping patients. They did think people were, being undertreated, and they thought opioids were safe. And I don't think that was based on good science, but they were, I think they
agree
did
with you.
believe it. Yeah.
People have they had good intentions, but they didn't see the catastrophe that was happening, right?
Exactly. I mean, the marketing was very powerful, and everyone knows the story of Purdue Pharma and the Sacklers now, but this was we knew about this back in 2007. I mean, people kind of forget this, but there was a federal case against Purdue Pharma in 2007. They pled guilty. 2 pharma executives went to jail. They pled guilty to a felony for lying that OxyContin was, less addictive than other opioids and safer. And people kind of somehow got brushed under the table. And but yeah, this was starting to come out,
Right.
I think long before people really realized.
And you and I lived through this history, we saw it happening. I see the emergency department where I work is like the canary in the coal mine. All of a sudden, our patient population changed, and California and other states passed pain bill of rights, all sorts of laws that are still on the books, where you have the right to pain, and doctors won't be prosecuted for not giving pain, but doctors did get sued for not giving pain medicines. And that just sent out a message to the medical community to prescribe. And patients would come in and they have like a little boo-boo on their finger, and they're like, "Doc, what are you going to give me for my pain?" And it's like, "Oh, whatever, here's some 20 oxycodone, have fun."
Right.
I mean, we were kind of bullied into that position.
I mean, it was a major change in practice. I mean, I think when, if you look back to the 70s and 80s, it was not standard medical practice at that time to use opioids for non-cancer pain or acute pain, right? That's what we used opioids for. If somebody had like low back pain or something, that was not something that chronic low back pain, that was not something that opioids were used for. That was kind of considered not typical practice, and
you also
that
had
changed very
triplicate
quickly.
Yeah, we had
there was a lot more
prescriptions, right? You weren't, if we did give pain medicines, we'd give a Vicodin or a codeine. We wouldn't go straight to
Right.
oxycodone.
Yeah, I mean, so there were a lot of changes, and you're right. Like in the 70s, 80s, people that prescribed opioids for things like chronic low back pain, were often worried that was, they were going to get, that they were practicing outside the bounds. And there were laws that were passed to, give, to not just make it permissive to prescribe opioids, but to encourage, or in some cases to kind of, almost make it required that if you weren't doing it, then you were. And this is what I was taught as a resident. I mean, when I did that first guideline, it was I'll just say it was very eye-opening, because, when we do these systematic reviews, I mean, I was trained as a primary care doc. I'm not a boarded in pain medicine or anything like that. I'm a primary care doc. And when we do these systematic reviews, our goal is to be comprehensive, look at the studies rigorously. And it was really kind of shocking, what the evidence was. Like if you looked at the trials and you're looking at the benefits of the opioids, they're pretty small. In many cases, no bigger than what you see for things like NSAIDs and stuff like that, and no long-term studies at all. Very selected patient populations, no data on overdose risk and things like that. And it's not just with opioids and chronic pain. I mean, this happens for a lot of things that we've done reviews for. But I think this is a particularly eye-opening case because you saw what was happening clinically, just how much practice was changing over a very short period of time.
It is. And there's so much to learn from this. If we could just learn from history, and we've lived it now, how it started and how it ended. I think there's a lot to learn with that. So you started doing a guideline in 2009. And is that how you got invited to help with the guidelines for the CDC in 2016. I noticed we look at the authors of the guidelines, they're all CDC employees except for you.
Yeah, so yes, I would say that's how it started. I mean, I often would give talks and things on the guideline. AHRQ actually commissioned us to do a review on opioids for chronic pain for an NIH consensus conference. So it was a Pathways to Prevention workshop. So NIH convenes those conferences to, kind of inform like what direction we should go in and what kinds of research is needed and those kinds of things. So I did a presentation. This was in DC, and I was approached by, this was I think 2014 or so, and CDC essentially approached me and asked, would you be interested in, CDC needs to address this. This is an important public health problem. And we think there needs to be some, national guidance. And they wanted to, I think they wanted to, they were worried about conflicts of interest in the professional society guidelines and things like that. So they were like, it's better for the government to do it. And yeah, so they asked if we'd be able to update the guideline, update the evidence review, and then, work with them on doing the guidelines. So, I actually had a professional development agreement with the CDC during that period. So I think technically that means I was, they were paying part of my salary. So technically I was a CDC employee, even though I was still at OHSU. Yeah.
Well, I met Dr. Debbie Dowell right after the 2016 guidelines were, and just thanked her profusely, and thank you too for putting that out there, because in the meantime, Washington State had guidelines. San Diego, we kind of copied some of the Washington State work and talked to them and had something locally implemented, but we were all working on our own, trying to do what we can in our community because people were dying. And when CDC put out their guidelines, that became the gold standard for the nation and really elevated our work. I thought they were fair. The only thing is they were called the Chronic Pain Guidelines, and I found them extremely useful as an emergency physician for acute pain. So I thought they were even a lot more than what they set out to be, and I think that made us all better doctors for it.
Well, thank you. I mean, I think that guideline did have an important impact on policy and practice. I mean, we did get criticisms for it, and I would say that some people, used it in ways that were not intended. And if you actually read the guideline, it says, that's not what they would do things that the guideline specifically said don't do. Like we would say, this does not apply to people who are being treated for addiction. This does not apply to people who are in palliative care, et cetera, and people would do it anyways. So it was a very interesting case, because normally that's not the case with guidelines. Normally with guidelines, like you're trying to get people to do, what's in the guideline. This is a case where people were kind of going beyond. But you're right. It's because there was at the time, prescription opioids were the driver of the opioid crisis and the overdose deaths. I mean, the epidemiology has changed, and I would argue that's in part because of, policy and, decreased use of prescription opioids and the availability of synthetic fentanyl. But at the time, prescription opioids were the driver of, the opioid epidemic. And I think that it did have positive impacts. I think the goal in 2022 was to try to, maybe emphasize or reiterate, our goals of, that the guidelines were always meant to be individualized and to, it's a patient-focused thing. And we never said you can never use opioids. We never said you have to taper everybody who's over a certain threshold. I mean, if you read the 2016 guideline, it doesn't say any of those things. It says, you do a risk assessment, right, risk-benefit assessment, and then you make your decision. I think the 2022 guideline one of our goals was to be even more explicit about that, and to support clinicians as well as patients in these processes. Though again, I would say a lot of the principles are quite similar. If anything, the evidence since 2016 kind of has, further, supported, a lot of the principles. That the benefits of opioids are really not that big, right? I mean, we've looked at this several different times. There's I think around 60 randomized controlled trials of opioids versus placebo. And, the perception is that, they must be, highly effective. But if you look at the actual benefit, it's less than 1 point on a 10-point pain scale.
Yeah.
And that's even when these are like the companies are they design these trials intentionally to try to get the best results, right? So they pick patients who they think are going to do better. They exclude people who have a lot of depression or have a lot of who may have substance use problems or other things that might, make it more difficult to treat them. They don't look at conditions that are harder to treat, things like fibromyalgia and stuff like that. And they do things with their study designs. I mean, if you're familiar with something that's called the enriched enrollment randomized withdrawal design, this is something that's become very common. It sounds complicated, and when you hear what it is, you'll think it's very odd, because in a normal trial where you're looking at a medication, right? You'll take a group of people and you'll randomize them to receive the drug or placebo, and then you see how they do. With opioids, industry and other people were, their concern was, well, how come we can't show that opioids work? We know they work. How come we can't show that they work? So they came up with this other design, which is this EERW, or enriched enrollment randomized withdrawal design, which is you put everybody on the opioid. Anybody who, has, intolerable side effects, you remove from the study. People that don't benefit from the opioid, you remove from the study. So you end up with people who have had a good response to opioids and don't have bad side effects. And then you randomize them, and what you're randomizing them to is, could they either get to continue the opioid that they've been doing well with, or you take them off. So it's a very intentionally selected population to try to get, that's why it's called enriched, because it's people who they already know have done well with opioids, and then they either allow them to continue or they take them off. And it's a very, strange design, but it's become one of the most common methods of looking at opioids. And even in those studies, the benefits are about, a little bit less than 1 point. So even when you take like the, people only, when you're only examining people who you already know have done well in opioids, and then you either let them continue or stop it, the benefits are still pretty small. And so, that's, I think, quite consistent. And as I say, there's been nothing in the last 6 years to have changed that. And, I think one of the, there have been some challenges. I think the tapering issue is a big challenge on how to do it and who to do it. And we still don't have a lot of data there, but that's another area that we try to address with a little more depth. And then, the acute pain part is another thing that is addressed more in this current guideline.
So that kind of like sums up Justin's question to our podcast and to you. Justin is an emergency department pharmacist. He makes me and all of our doctors a lot smarter with the more increasing complexity of medications in the emergency department. And so his question that I'm going to adjust to you is, what are the essentials in the new CDC opioid guidelines for pain? And his second part of the question is, will there be a third guideline or a regular addition to this, kind of like the CDC puts out for sexually transmitted infections? Is this going to be an ongoing thing?
Yeah, those are both great questions. And, So from the ER standpoint, I'll say that the key additions or new aspects include, so in the 2016 guideline, we did a very limited, supplemental review on acute pain. It wasn't any, and we did a much more in-depth review, again, commissioned by AHRQ for the 2022 guideline. And some of the findings were surprising. So remember I said before that for chronic pain, we found that, opioids aren't all that effective. But we were also starting to look at, if you look at that for acute pain, you actually see some of the same things. So for dental pain, it's actually quite clear that NSAIDs are at least as effective as opioids for most dental pain, wisdom tooth extractions and whatnot.
So I never give an opioid for pain because I'll get the pain score to a 0 with a dental block, with a long-acting anesthetic. And now you're going to be pain-free, 0 pain, with a quick dental block instead of giving a prescription for opioids. That's, or even a shot of Dilaudid. That's not going to help as much.
Yeah, like I said, even NSAIDs, like I said, are at least as effective as opioids. And one of the things we looked at was kidney stone pain, which when I was training, I was always taught this is one of the worst, most intense pains you could have. People say it's similar to childbirth or something. And, opioids are kind of standard practice. But, there's a few randomized controlled trials that show that acetaminophen and NSAIDs are about as effective as opioids for kidney stone pain. So that is pretty surprising for some postoperative pain, NSAIDs look. So, I think that's one of the newer messages. Again, it's not that you can't use opioids for, if somebody has had major surgery or major trauma or something, obviously, opioids are appropriate. But there are a lot of types of acute pain where it's not necessary to use opioids. People actually may do better with other drugs, and certainly some of those other drugs may be safer. And I think the other thing that we've learned, over the last 5 to 10 years is just how much, there's so many, when people are prescribed medications for acute pain, whether it's after surgery or for, a dental procedure or something like that, there's tons of unused opioids. So there are some studies that show, like, on average, people are given like a prescription of 30 or 50 pills and they use 8, that kind of thing. And of course, that's very highly risky because a lot of these opioids sit around in somebody's cabinet. It's actually not easy to get rid of opioids, right? You're not really supposed to just toss them in the trash, and, the pharmacies aren't allowed to take them back unless they have, special, boxes and things to set up to dispose of them. And so you have a lot of unused opioids, and, people can get access to those. And so I think the other message is, not giving big, amounts or tailoring that to the anticipated duration of pain.
Right. The surgeons would give like a bottle of 300 pills, and like you said, the patient would need 8, and so the paradigm shift is now give a small amount and then give refills instead of giving like a bigger amount.
Exactly. If people, we want people to have follow-up and be able to, so if somebody is having more pain, that's actually something that the primary care doc or whoever's following the patient should know. And so, if somebody has, so again, trying to, this is trying to use data, right? It's actually, studies that show that there's tons of unused opioids. And so we try to incorporate those considerations. We tried to look at other non-pharmacological therapies for acute pain, and there are some data on some things like TENS and, massage and things like that. So there are some other options that can be used. I think from the pharmacist perspective, one of the important things are drug-drug interactions. And, and this is something that's, I think, emerged in the last, some of the data was just coming out in around 2016, but, on the risk with opioids and benzodiazepines, where we see, sometimes a doubling or tripling of risk of overdose when you combine those drugs. But there's also data on opioids plus things like GABA, other drugs that cause some CNS depression, so gabapentin and pregabalin, and things like that. And I think not all clinicians were aware of that. We now have tools to, look for those types of interactions in the PDMP. Many states now have laws about requiring people to access the PDMP. And actually, many states have laws about the amount of opioid you can, how many days of opioid you can prescribe for, somebody in the ED, for example. So a lot of things like that. From the ED perspective.
Interesting. So,
and then in terms of updating, I don't think that they've made a decision yet. I mean, this is a long process. If you read the guideline, there's a long process from commissioning the reviews and doing the reviews, and then starting to do the guideline. There's a lot of input from the public.
Several years,
from
right?
other
It
federal
took several
agencies.
years to...
Oh yeah. It's a very long process, and so right now I'm not aware of a specific plan. I do think CDC wants to keep it updated, and especially if there's new data or things that emerge, they would want to address that. But I'm not aware of a specific timeline at this point.
Interesting. A little bit about the guidelines. By the way, if there was a third version like coming up, I would change it to, the first one was called chronic pain. The next one was, opioids for pain. And my conversation to the medical community now is just about safe prescribing, not just opiates, right? You have to talk about benzodiazepines and other drugs out there, and all the different drug interactions for various different things. And if we look at medical examiner, and this is what guides me, if I look at medical examiner data of why people are dying of medications, we know the illicit drug is fentanyl, number one, methamphetamine, number two, from illicit drugs. But that doesn't come from the medical supply. If we look at the medical supply of deaths, that's what really directs me as what I could do to prevent people from dying from the medicines that I prescribe. And that's a combination. It's not just one drug. Right.
Yeah, I think I would agree with that. I mean, it is about prescribing opioids in general. And I'll also say there's so much, how we use opioids for pain and, the issues with opioid addiction are very closely interrelated. I mean, there's a really interesting study that looked at, what they did was they talked to, or they surveyed heroin users, and they asked them what their first opioid of abuse was. And it was based on when they started using heroin. And when you talk to people in the 60s, 70s, it's overwhelmingly heroin was their first opioid of abuse, right? And then that switches, it reverses in around 1990, where if you talk to heroin users... If you take those
same patients with the heroin that you went back with the heroin and opiates, if you kept asking, well, what's the first drug you ever used ever? They'll say marijuana.
Right. Well, now they'll say if it's the first opioid of abuse, they'll say it's a prescription opioid.
Because you asked the wrong question.
Yeah.
You should have said what was the first drug instead of the first opioid. Interesting.
Yeah, I mean, marijuana is, it's so ubiquitous. I mean, I live in Oregon where it's, you can literally get it delivered to you on a bicycle if you wanted to. So it's ubiquitous. I think that creates other, that brings up a whole host of other. We're gonna talk
about marijuana a little bit, but I want the guidelines. Was there anything outdated when you read? Was there anything? Okay, this is wrong when we looked at it again that you needed to remove, or did you only add and hone in some things?
I think it was mostly clarifying things. We did take out some of the language of where we specified So in the 2016 guideline, we said, use caution when you get to 50 morphine equivalents, and then avoid, higher than 90, or, if you're going to use higher than 90, that has to be based on a careful assessment. And, things like that were taken out. We also said for acute pain, usually you need less than 7 days. And it was felt that those parameters were maybe too prescriptive. And so if you read the top line recommendations, at least, they're not, those kinds of things aren't in there. It's more about, individualizing to the patient. Another thing in the 2016 guideline is it's not in the top line recommendation, but in the text, when talking about tapering, there's some language that says, you can taper people by 10, a rule of thumb was to taper people by 10% a week. And, anyone in clinical practice knows that somebody who's been on opioids for many years, that can be extremely fast. That means going from, 100, on your current dose to 0 in 10 weeks. And for many people, that's very difficult to do. And so, we do talk about using longer tapers. I think we're also gaining more experience about how and when to taper, the need to provide, adequate psychological and other supports for people undergoing tapers. I don't think this is in the guideline, but, I've also written with some other folks, we do have this phenomenon where there are people who, have chronic pain, are prescribed opioids. They don't meet any other DSM-5 criteria for opioid use disorder, except you can't taper them, right? Every time you try to drop their dose, they have intolerable side effects. Their pain gets really bad. There's this, they're in a ton of distress. And so they kind of fall in between, a DSM-5 diagnosis of opioid use disorder and, the condition that they're having. And, in my opinion, those patients are a tough challenge. And in my opinion, and the reason you're tapering those people a lot of times is because they're at high risk, right? They've exhibited that they, that they, are having, they've maybe had an overdose event, maybe they've, had multiple, they've lost their prescriptions a few times, something like that, whatever. But there's some risk that you're worried about. And some of those patients might do better on something like buprenorphine, but they don't meet the classical criteria for opioid use disorder, or if they do, it's kind of a, kind of on the borderline. So we're learning about things like that. I mean, there are some data about people having bad outcomes if they're suddenly taken off their opioid. Which I don't think is a surprise. We always knew that you should not stop opioids suddenly, but we, emphasize that in the report. There's a lot of concerns about, people having bad outcomes from tapering, and we discussed that in the guideline. I'll just say that I think those studies are very hard to interpret. Most of those studies are based on, analyses of databases, so they're looking at large databases, and typically you don't have any idea why the opioid was stopped or why it's being dropped. You don't have any idea about what other things are being done to support the patients. You just have no idea what the clinical context is, and probably a lot of those people who are being dropped on their opioid dose are being dropped because they're high risk, right? So there's a lot of confounding there. So I think those studies are very hard to interpret. I wish we had better studies on, how to taper and
well, the Medical Board of California was going after doctors for prescribing. They made a 180. They were, 10 years before going after doctors who weren't prescribing, and then they sent 500 letters to physicians who had someone who died years before. years before the CDC
Right.
guidelines were even published, with the threat of losing their license. So that sent a huge alarm in California to physicians in fear. And I think the medical board has blood on their hands because physicians were scared, cut patients off for fear of their license. And I've talked to loved ones whose family members committed suicide because they were just cut off and didn't, and that's
Yeah.
not the intention.
Yeah, no, it's terrible, and you're right. That was not the intention. And we actually wrote an editorial in New England Journal of Medicine, I think in like 2019 or so, saying you shouldn't be, that's not what the guideline says to do. You don't stop people suddenly. You need to, if you're going to stop, you need to taper them in appropriate ways. If somebody has opioid use disorder, you need to treat them for their opioid use disorder. I mean, I still think that's a huge problem, undertreatment of opioid use disorder, and just kind of related to what you were saying before, it kind of goes beyond just how do you use opioids for pain. It's kind of how do you use opioids in general. I don't think that, the CDC, the guideline is not meant to address, treatment of addiction. That's a whole other area. But I think this overlap between addiction and pain is really important. The guideline does touch on it. But I feel like that's still a big, need to make sure people have access to appropriate treatments. The old way of doing this was if somebody was having a problem with their opioids, say they were escalating their doses, they were, doctor shopping and getting opioids from multiple docs, the response was, we're going to cut them off and discharge them from our clinic, right? And
Right.
That's probably somebody who has opioid use disorder, somebody who's, unable, engaging in those types of behaviors. And the standard of care is to treat them with a medication. I still think, I think we're better now than we were maybe 10 or 15 years ago, but there's still a lot of, there's still a long way to go there.
Right. Definitely could do things safer. I help with a course called Innovations in Safe Prescribing that was commissioned by San Diego Public Health. And I used a lot of the CDC old, you have not just the guidelines, but there was a lot of assist devices like start slow and go slow. Start low, go slow. Is that still in effect?
Yeah, definitely. So the initial period of when you first start opioids is a high risk period for overdose. If you look at overdose risk, it's something like two or three times higher in the first few weeks, because people don't have tolerance yet. And so yes, we want people to start low. That used to be a big problem with methadone. If you remember when we were using methadone a lot.
People were dying of methadone.
Pain, because it was cheap, right? It was, methadone was a few pennies compared to OxyContin, which was like, maybe $1 or something a milligram. So a lot of, formularies, methadone was a preferred drug, but methadone is very tricky to use because of, long half-life and variable half-life and all this stuff. And, people were overdosing because people were starting on doses that were too high and then increasing them too soon. So with methadone in particular, but with all opioids, people who are not tolerant, in general, you want to start low and titrate, slowly, and the risks of using high, doses that are too high are, the risk is overdose, and so
the study I did with the medical examiner looking at all the medication deaths, I said usually 80% of the time people die of a cocktail, not just one drug. But if there was one drug that was just, a straight kill with no other drugs, it was methadone. The other thing that CDC guidelines said, don't start without I want to ask you several things to make sure, selfishly, if it's still applicable to our program. So don't start without a plan to stop. Is that still part of the guidelines?
Yeah, I think that's an important principle. And I think that was, and a lot of that is based on experience. That if you, that it was a lot easier to start opioids than to stop them, and that was a big problem, right? We had so many people started on opioids. I mean, we are using more opioids in the United States than any other country in the world. Right. And it was very hard, and we know that it's much harder to stop opioids than to start them. And so, the principle is that when you're starting opioids, you want to have, what are your goals? What are you trying to achieve? What are the things that would make you think that, you need to stop, that the benefits are not outweighed by the harms? And how are you going to do it? Like, how are you going, and patients should know about this going in, that it's not that you're going to be put on this drug and just kept on it forever, that they're going to be reevaluated, just like any other drug. If we put somebody on a cholesterol-lowering medication or something, you monitor them and you see what their response is. And if they're having side effects, you make adjustments or you try a different medication. I think it's the same with opioids. And so we think that's an important principle, and I think it still holds. And, especially the goals of treatment. I mean, in the past, we really focused on, pain, which is important, of course, but we also want to know, what is maybe as important or maybe more important is what people can do, right? So it was very common in clinical practice for people to come in, visit after visit and say, yeah, my pain's better on the opioids. It's a 6 now instead of an 8. But then you'd ask, well, are you working? Are you, attending your, kids, ball games? Are you participating in other social activities? And the answer was often no, I'm not doing any of those things because of pain. And so, having more of a focus on function as an important goal. And then, really, I try to talk to patients about this and try to understand, what is it that they're, what that we're hoping to achieve. And then if we're not achieving that, then you need to make some decisions about, does it really make sense to continue a medication that has risk, but is not accomplishing what you're hoping.
Right. The other thing I saw on the guidelines is the 4 A's, and I added my 5th A. So the 4 A's were analgesia, activities of daily living, like you mentioned, adverse effects and aberrant behavior. And then I added another A for additive. And that has to do with the benzodiazepines, the Benadryls, again, the gabapentin, the cannabis, because those drugs are additive in their effect and making sure that they're not there.
Yeah, no, I think that's important, and that's a good addition. And the idea really is for people not to focus just on, pain relief, which is analgesia, but to think about, what the impacts are on the patient as a whole. And, making your judgments based on all of those things. And if somebody, needs high-dose benzodiazepines, that's a high-risk situation. And, personally, I think as a physician, you'd be at, some, risk if you prescribe that, if you prescribe that combination and somebody had a bad outcome. And of course, we don't want patients to have, those kinds of outcomes. And so, I think the additive, meds or however you phrase that is important and a good addition.
Yeah, thanks. So I have something that, as a scientist and someone who reviews articles for the government will be very, very helpful for you for your next guideline. Are you ready?
Yeah.
Okay. It's called Goldilocks prescribing. Not too much, not too little. It has to be just right.
Yeah. I mean, that's the goal, and that's what we always intended. So, again, if you read the 2016 guideline, that's kind of what we were saying is, it's not don't ever use these, but use them when it's appropriate, stop them when they're not working or when they're harming patients, I think the 2022 guideline perhaps is clearer about that, or, there's a lot of text that, there's we have like separate boxes and stuff that really kind of talk about this and specifically say, don't do these things. But but yeah, it's about, managing patients, individual patients, and yeah. So I think that's right. It's getting it just right.
You have to get it just right. And that's something that we are taught in medical school, and we do understand as providers. And that's probably why the CDC calls this a guideline and not a protocol. So when we wrote our guidelines in San Diego, we made sure they're called guidelines, not a protocol, because every human being is different. Every situation is different. And we do that as physicians. But sometimes when the general public reads things, they take it very literally, and that causes, controversy. And so I bet you experienced a lot of that politics when you wrote these guidelines. Were there people angry at again and when they about these guidelines, or was it calmer than the first time?
I don't know that it's calmer. I mean, the guideline got, I think, 5,500 public comments or something like that, which,
wow.
We do a lot of federal, I do a lot of work for the U.S. Preventive Services Task Force and other groups. And, for a lot of those reports, public comment is, I don't know, 5 to 20 people maybe. So 5,500 is, that's, a couple of orders of magnitude higher. And it was similar with the 2016 guidelines.
How do you manage that? There's a lot of, I don't know if you get such comments when it comes to, sexually transmitted infections and antibiotic choices. But with this, you've got like every medical organization, people, parent groups, pain groups, every side, like making their comment, putting in their point of view. How do you manage that as a scientist who's writing a guideline?
I mean, it's a challenge. I think I think there's a few things we do. I mean, one is, we think the guideline needs to be, grounded in the scientific evidence. And so, we do the best job we can to understand what the science is telling us, what the benefits and harms are, and, using that as the basis, right? So that's the first thing. I think, we also, and we do try to take into account, feedback and patient and public comments. So, the CDC actually spent quite a bit of time. I think they actually did individual interviews with, a random sample of, people to get even more in-depth feedback. And we include, the CDC included patient, stakeholder perspectives in the guideline development process itself. So in the working group, there are, folks who represent, the patient perspective. And so I think there's a lot of things that we do. And then I'll say the third thing is just the process. So, we try to stick with, we try to use a process that is transparent, that shows all the steps and kind of all the stuff that goes into the guidelines. So, people may disagree, but at least they can see what what it's based on. I think scientifically, I feel confident in our interpretation of the evidence from a scientific basis. And like I said, so, people may disagree about certain aspects of the guideline or how things are phrased, and those are the kinds of things that you need to be thoughtful about. But yeah, I mean, I think in the end, you do need to consider, the input and critiques and take them seriously. But again, everything has to be, kind of grounded in, the science.
Yeah. And the CDC is known for that. I think you do an excellent job. And it really is the gold standard for the medical community. And it needs to be clean of, political agendas and just the science. And I think you've done that in all the publications really that the CDC has put out. I wrote in a comment. I don't know if you read all, what did you say, 5,000 comments that you received?
About 6,500.
6,500 comments.
Yeah.
So I was one of the 65 comments, and I don't remember exactly what I wrote, but I put in something about I wanted to make sure that the issue of cannabis additive effects, like because the additive effects of opiates, not just for benzodiazepines and gabapentin and Benadryl, but also for marijuana, and they were kept in there. So I was happy to see that.
Yeah.
And I was wondering how much of that was controversial. Did you get the marijuana industry of the pro-cannabis folks trying to get that out, keep it in, keep it out? How much?
Yeah, I don't remember that being a huge focus. I think in part because it's not a top line recommendation; it's more in the text, but also that the evidence is still, pretty preliminary. So I mean, earlier before we got online, we were talking. We've been doing a review on cannabis and other plant-based substances, so things like kratom and stuff like that, which some people think.
And you're doing that review for the federal government?
Yeah, that's being done for the Agency for Healthcare Research and Quality, and that's an ongoing review. So it's a living review, which means that we keep, continuously search the literature and update as new studies come in. The evidence is pretty limited. We've actually tried to look at, how cannabis use impacts opioid use, right? So if somebody is taking opioids, does, adding cannabis allow them to decrease the amount of opioids they're using? And so far, the studies just don't really report on that. So we don't have a lot of information on that.
Or if anything, it happens the other way around, right? People who are using chronic marijuana, they have a harder time managing pain. I think if you asked our trauma centers, they would also say they have a harder time, in their rehab.
They may. I mean, again, I feel like the evidence is pretty limited at this point and a little bit mixed. I mean, there's some studies that suggest that, cannabis may have some beneficial effects on pain, and whether they, increase or decrease opioid use, I think is a little bit unclear at this point. But cannabis is really complex, right? Because it's not a single substance; it's many substances. So, THC and CBD are probably the most prominent, but there's a lot of other things in there, and then also potential contaminants and things like that, and other compounds if you're looking at, plant extracted substances and not like a pure, synthetic product. So there's all sorts of complexities here. It really, in my opinion, I think the perception of cannabis is that it's kind of this one thing, and it really isn't. That, CBD predominant products may be quite different from THC predominant products in their effects, and we need a lot more data to understand, a lot of these things. And, I think there. Oh, go ahead.
No, so when you said we have very limited information, I think, and you correct me, but you have limited information to show that it's good. I think we have tons of information and literature that emphasize the harms. And like the National Academy of Medicine that we both served on published a marijuana report on various benefits, completely ignoring the various harms. And I feel like I'm reliving history. Years ago, I was seeing all these patients, and we talked about in the emergency department, who were there seeking opioids. And now every shift, I see marijuana poisonings, cannabis hyperemesis syndrome, cannabis-induced psychosis. There's I did a whole podcast on parents who've lost their children to cannabis-induced suicide, drug interactions, skyrocketing number of geriatric patients coming in the emergency department that was recently published. I think we have plenty of research to show the harms, and yet whenever it seems to me, and please correct me, but when, National Academy of Medicine, or I don't know if AHRQ is doing this too, they're looking at potential benefits, but you can't do that as a doctor. You can't recommend something based on the benefits without a balance of the harms. And I see that now with
No,
doctors, because they were cut off from opioids, right? Okay, well, the government's looking at my opioid prescribing, and they're telling their patients to just use marijuana without the science, without looking at the contraindications.
And yeah, so I totally agree that when we look at drugs or other medical interventions, they need to be you need to be balanced, and so you need to look at benefits as well as harms. One of the problems with opioids and cannabis is that, at least in a typical randomized controlled trial, they're not designed to look at those types of harms, right? Because they're picking patients who are lower risk. They're not picking people who are going to misuse or at high risk of misusing or having
isn't that a problem
use disorder. It is a problem, and so if you look at the randomized controlled trials, they don't tell us anything about, cannabis use disorder risk because first of all, they're too small to really give us any, reliable information. But certainly, things like hyperemesis and things like that, the studies just aren't designed to look at those things. There are other sources to look at those types of adverse effects, and I agree that that the harms of cannabis are probably underestimated, and people kind of ignore them. But I think it's the same with like alcohol and a lot of other substances that are,
What's different with alcohol, and again, you could disagree, but I think what's different with alcohol is people know the risks. Right? There's dietary guidelines out there published by the National Institute of Alcohol Abuse on alcohol. We know that, drinking too much, you shouldn't drive when you're drinking, and we know that it affects your liver. We know those things. The difference with marijuana is that people are told, oh, it's harmless, it's okay, it's natural, it'll help your anxiety, it'll help your pain, better than those terrible opioids. And they're pushed on society, like opiates were pushed on the medical profession.
Yeah, no, I mean, first of all, I'll just say on that I agree that the evidence to support, using cannabis to treat pain is very limited, and in my opinion, it's not there. And I think we need a lot more research, and I think the research, we would be well taught to do the research. One of the problems with cannabis is that the research has been very restricted because the federal government has, traditionally at least,
Dr.
not
Chou,
funded research in this area.
What's missing in the research for harms? The people who say we're missing research either want to do more research or they want to show that it's good for you. I think I can quote, more research than the surgeon that is out there on the harms than there was for the Surgeon General when they said, the warnings for tobacco. Like, why are we not paying attention to the research that's already there?
All right. No, so I'm not saying you should ignore that research, but what I'm saying, for example, if you're saying, should somebody use cannabis instead of an opioid, we need a study that compares people that use cannabis and opioid, and people that use opioids for pain, and actually says, how many people are experiencing this side effect with cannabis versus, and so you need to be able to weigh those two things, and we don't really have the data to do that.
So what's wrong? What's wrong with my thinking as a physician to say today, don't use cannabis for pain because one, we don't know that it's better. Two, we have other options for you, and three, I could give you 10 side effects that I don't want you to develop because of that.
Yeah, I don't think there's anything wrong with that.
Right. Okay.
I think that's a very valid perspective. But there are people who, there are people who would say, well, I know that the opioids have a much higher overdose risk, than cannabis, and I'd rather have people on, cannabis if you have to choose. And so that's another perspective. It's not one that I necessarily agree with, yeah.
I find that really hard because, the other people I've had on the podcast were into prevention science, and we talked about how the National Academy of Medicine is working on this, patient journey. If you look at the patient journey and you go downstream the downstream is someone overdosing on opioids. And if you go upstream, they started using opioids. And if you go upstream from that, you see marijuana use. And if you go upstream from that, there's some hole in someone's heart or anxiety or whatever that's made them want to use drugs in the first place. So to ignore that upstream effect and say, okay, well, here, just use marijuana instead of opioids. You just may have set up, especially kids, you just committed them to a life of psychosis and anxiety, worse anxiety, and other problems besides an overdose. I would love, I talked to the CDC also has a unit on cannabis. Wonderful, wonderful people who are doing great work, just like the unit that was working on opioids. And maybe one day they'll take you and ask you to do a guideline for them on what physicians need to know, and patients need to do on cannabis. I feel like I'm reliving history because I actually wrote such a guideline for the medical community. It's published by ISAC, the International Academy of Science and Impact in Cannabis. I'd love to share it with you, get your input. Not judgmental, not like what I said, don't use it. Saying like your patients are using it. Just like you said, it's ubiquitous in Oregon, it's ubiquitous in California, but these are the things that you should know. Your patients are using this. These are the things that you should know. And it's about making informed risk-benefit decisions. And so who knows, maybe your work now with AHRQ and your experience with CDC opioid guidelines would lead you to the next step.
Yeah. I totally agree with everything you said. And I think that, as I said, I think it's too early to know that cannabis is a safer alternative or what the effects are really. I mean, it's very preliminary. I actually, one point you made about, cannabis use in kids. I mean, it's in Oregon, it's very common in middle school and high school. And it's very concerning because we know that, early use of these substances can have, effects on brain development and, risk for, substance use in the future. So I think that these are all totally legitimate concerns. I mean, I feel that this is, again, there is evidence out there. It's hard to, it's not the same type of evidence, that usually we can, make strong conclusions from, at least when we're trying to compare different, treatment strategies. And that's why we need better studies. And again, the federal government has not traditionally funded a lot of research in this area because of, regulations and prohibitions about cannabis research. But that does seem to be changing. And I think we will have more information.
And if it has therapeutic value, then it needs to be regulated by the FDA like opioids are, or aspirin and nonsteroidals, and not what's happening right now.
Yeah, no, exactly. Yeah.
I want to say thank you to Justin for great questions and your ability as an emergency department pharmacist for elevating the care that we provide in the emergency department. And thank you, Dr. Roger Chou, for the CDC guidelines, elevating the work we all do across the nation as providers in being safer in managing pain and using opioids, and providing the gold standard in a very tough political environments by sticking to the science. And I really want to thank you for that.
Thank you. Yeah, thanks for having me. It was great to chat.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to ISAC, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit ISAC1.org, that's IASIC1.org, to view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Onit Lev. We hope we brought your day a little bit more High Truths.